So this is avascular necrosis, leg calviparthase, and Osgood-Schlatter's. So avascular necrosis is exactly what it sounds like. It's when the blood supply to the bone gets disrupted, and then the bone dies and it disintegrates. It doesn't get replaced when that happens. It depending on where it happens, it can have secondary complications. It can increase the risk of fracture. Most importantly, if it happens like in a joint area, which it often does, it can lead to osteoarthritis. So it happens usually in middle-aged people or in young boys. Like calviparthase is a version of it that happens in boys. We'll talk about that in a minute. But really, what happens is that something disrupts the blood supply. The head of the femur is the most common place for it to happen, and anything that disrupts the blood supply can do it. So this is it could be a blood clot, any sort of trauma. People fall on their hips and disrupt that blood supply. It can be microcirculation. I've heard it said that smoking will lead to it, and so will diabetes, because those things disrupt the peripheral vascular. Other places that it happens is the scaphoid or the talus, the proximal humerus, or is around the shoulders, and the tibial plateau often happen. And mostly it's because of the structure of the blood supply in those. The scaphoid is a particularly nasty one because the nutrient artery enters from one end of the scaphoid and has to cross the entire scaphoid. So there's not multiple collateral routes for blood to get there, and it's the same with the head of the femur. There's not a lot of collateral routes, so if that blood supply is disrupted, then there's not a lot of choice. It doesn't take a lot of disruption to cause a problem. It's so on page 669 of your book, it talks about it in as little as 2 hours of complete ischemia for permanent loss of that bone tissue. Now here's it looks like maybe the proximal end of a humerus here. It might be a femoral head. Actually, no, I take that back. It is a femoral head. And you can see that the necrosis right up at the top here, right under the joint cartilage. And that will be a permanent misshapen of the head, so the ball that goes in the socket. It's a problem on its own, but the problem becomes even more so when what it does to the joint and how it causes the joint to misload, and it'll lead to osteoarthritis. So lots of things that can do it, and almost anything that will disrupt. So autoimmune diseases, pancreatitis for some reason seems to be able to do it. Blood disorders like hemophilia, sickle cell, decompression sickness, the bends from diving can cause it. Anything that disrupts the peripheral vascular circulation, like things like alcoholism, diabetes, smoking, that sort of thing, can all lead to it, which really, when you think about it, middle-aged men are the prime candidates for that. It's seen way more often in white people than other races. So Caucasians seem to get it more. So what happens? The joint becomes painful. Like you can just imagine that, but it looks like osteoarthritis, and it will lead to osteoarthritis. They diagnose it by imaging, so CAT scan, later MRI, those sorts of things. What they try and do is not use the joint, so you brace, you do that kind of thing. You if there's a decompression, if there's a joint collapse, then they might do surgery to try and rebuild it to stop further complications. Now, when it happens in kids, it's called leg calviparthase, sometimes called coxaplana, which means flat hip. Osteochondritis deformans juvenalis is another name for it. So it happens to be that. It has to be at the proximal end of the femur, at the femoral head. And what happens is at the time of growth, there is the epiphyseal plate of cartilage, which is avascular, completely across the neck of the femur, and the blood supply to the epiphysis comes through the ligament of the head of the femur. It comes down the middle of it. So the ligamentum teres is what it's called, but it's ligament of the head of the femur, the one that goes into the fovea capitis there. Now, normally in kids, that ligament is involved with this artery. In adults, that artery deteriorates and goes away, and you're left with this connective tissue ligament that doesn't serve a lot of purpose. What can happen is if that closes too early, if that artery starts to go away, then you get a lack of blood supply going to the area, because the epiphyseal plate is blocking it coming up from the rest of the femur. And then what has to happen is that the only blood that gets there goes on the blood vessels that pass over the surface of the neck, and they're not very big, and they have to enter the epiphysis above the growth plate, and it's not a very adequate way of doing it, and it's prone to disruption. So so it will slow it'll slow the growth, but B, it can cause necrosis. So when it happens, there's kind of an insidious onset of pain in the hip, and it's an aching stiffness. So a lot of times it's passed off as growing pains. But then you start to get a limp because the joint doesn't move freely. Now, the femoral head will actually not be completely round, and it can lead to problems later in life. I have a patient right now, well, actually, I had a patient. He just passed away of a different issue, but he had leg calviparthase when he was 10, and he's 55 when he passed away, and he had osteoarthritis of the hip that was involved in, and they were talking about doing a hip replacement surgery. They probably would have done it, except that he had a heart condition that, like a completely separate issue, and it was too dangerous to do the surgery. But I have actually never seen it active in a kid. They don't tend to end up on our tables at that age. they more go to the family doctor, but I have seen the aftermath, the OA later. You do Patrick's test to see that range of motion. So Osgood-Schlatter's I talked about in the presentation, the synchronous presentation, but what this is inflammation where the quads attach to the tibial tuberosity. So this is found on page 674, 675 of your textbook. It happens in athletic children. The tibial tuberosity is kind of a secondary ossification center, and there is cartilage that joins it onto the rest of the tibia. And the quadriceps are very powerful muscles, and they attach via the patellar tendon to the same spot. It's saying running and jumping sports here. It's been my experience that it's skating more often. Hockey players and figure skaters are really, really prone to it. I understand that there is a high incidence of it in Canada because of the amount of skating that we put our kids in. When you look at it, this X-ray shows that the tibial tuberosity is really becoming avulsed off of the rest of the tibia, and you can see that it ends up sticking out, pointing out. So it's really kind of a tendinitis. It's kind of that kind of thing, but it results from overstrengthening a muscle that's attached to an immature bone that's not ready to take that kind of thing. And it comes from repetitive stress. Like it's not a complete one-off avulsion. It's thousands and thousands and thousands of minor tugs that start to crack that cartilage and pull it away. It's stress at that attachment. So the tibial tuberosity starts to enlarge. It's often unilateral, but it can be bilateral, kind of depending on the sport. And it's an acute pain. It gets hot and swollen, and it's really tender to the touch. You can often see the tibial tuberosity showing up. Like you can see it actually pushing through, and becoming enlarged. Now, oftentimes, it's very common. I normally, there's people in every class that have it, or have had it. My brother had it, that kind of thing. There's all kinds of people have it. And when it heals later, they end up with rather large tibial tuberosities because of it. The usual treatment is actually to stop the activity that is causing it, which is a very, very difficult thing for a young athlete. Like somebody that's, a AAA hockey player is not wanting to take 2 years off of the game or a year off of the game because they'll never catch up again. The same with figure skaters. So those competitive athletes would rather endure the pain than actually quit the sport. So you got to really warm up before activity. There's a cooling down helps. If there's a complete avulsion, it might take surgery, but it's a difficult thing because it's oftentimes it's the first time a young person's body has failed them in their sport or in their activity. it hurts, so you got to be careful around it. When it's in the healing stage, maybe working on the quads is a good idea and will help.